Good afternoon. Hello, and thank you for joining us today. My name is Dr. Emily Volk, and I am the president of the College of American Pathologists. I'm the chief medical officer at Baptist Health Floyd in New Albany, Indiana, and an associate professor of pathology at the University of Louisville School of Medicine. It is my privilege to moderate this session. The CAP is the largest association solely representing board-certified pathologists in the United States. The CAP is also a laboratory accrediting body for almost 8,000 laboratories worldwide. Pathologists and the laboratories we direct continue to be on the front lines of this pandemic, alongside laboratory scientists and our physician colleagues. The CAP is committed to providing members of the media and the public with the most up-to-date information when it comes to testing for COVID-19, its variants, as well as other diseases and viruses. I'd like to welcome our other panelists today. Dr. Jonathan Miles. Dr. Miles, please tell everyone a little bit about yourself.
Good afternoon, and thank you for joining us this afternoon. My name is Dr. Jonathan Miles. I'm a member of the Board of Governors of the College of American Pathologists and chair of the CAP's Council on Government and Professional Affairs. I'm also a staff pathologist at the Cleveland Clinic in Cleveland, Ohio.
Thank you, Dr. Miles. We are also joined by Dr. Bobby Pritt. Dr. Pritt, please tell everyone a little bit about yourself.
Thank you, Dr. Volk. Good afternoon. I'm Dr. Bobby Pritt, and I am a pathologist with subspecialty expertise in medical microbiology. I am also a staff pathologist. I serve at Mayo Clinic, where I am the chair of the Division of Clinical Microbiology, and I am on the CAP's Board of Governors and the Council for Scientific Affairs. I'm also the immediate past chair of the CAP's Microbiology Committee, and I served as chair in 2020 at the very start of the pandemic.
Thank you, Dr. Pritt. And thank you all for joining us today. We will be discussing how laboratories are preparing to ensure they are ready for future waves of COVID variants and other pandemics, the current impact of COVID-19 on pathologists, and access to laboratories, especially for patients who need critical diagnostic care in healthcare deserts, both rural and urban areas. So let's begin with our first topic, the impact of COVID-19 on laboratories and how they are preparing for future waves of new variants or spikes in cases, as well as future pandemics. Dr. Miles, how can laboratories ensure that they have testing resources in place for new COVID variants and future pandemics?
Well, access to testing supplies affects patient care and the ability to get the tests they need in a timely fashion. Testing is important for a couple of reasons. One, the patient needs to get the right diagnosis so the right treatment can be instituted. And also, the diagnosis needs to be made so any mitigating measures can be put in place to prevent the spread of disease. We at the College of American Pathologists have engaged with the Biden administration throughout the pandemic on securing assistance for laboratories and pathologists to mitigate the supply shortages, as well as offering financial assistance to our laboratories to get them through the pandemic. One of the lessons that all laboratories have learned through this pandemic is to be flexible and to remain flexible for future pandemics. We've learned to be flexible in our supply chain, as well as flexible in the way we perform these tests by having multiple platforms available to perform COVID-19 testing. Also, the government and its regulatory bodies also need to be flexible when dealing and preparing for future pandemics, and flexibility in terms of approving tests that can be performed, and also flexible in regulatory regulations such as the remote work waiver, which allowed pathologists to work away from their typical practice setting. This did a couple things. One, it preserved our workforce by limiting pathologist exposure to the COVID-19 virus. and it also enabled pathologists to take care of other responsibilities that they had outside the workplace.
Thank you, Dr. Miles, for telling us all the different ways that supply chain shortages have been mitigated in the last 2 years. I really appreciate that. I know in our laboratory, we've had to flex going between different platforms and adjusting based on the supplies that we have for different tests. I appreciate your insights, Dr. Miles.
Yeah, early on in the pandemic, there's no question that supply shortages were rampant. What we have seen is that supply shortages have been somewhat mitigated since the Biden administration did provide funds to get supplies for COVID testing. But throughout the country, there are still spot shortages occurring.
Absolutely. Thank you so much, Dr. Miles. Dr. Pritt, what have you noticed at the Mayo Clinic? Have COVID-19 testing supply shortages impacted you there, or have they been mitigated?
That's a great question, Dr. Volk. I agree completely with Dr. Miles. It has been challenging. There's been some improvements, but early on in the pandemic, everyone's focus, all of the pathologists and the laboratories they direct, was just getting COVID tests. And at Mayo Clinic, we were facing the same limitations. And if we couldn't buy a test commercially, we tried creating them and would implement laboratory developed tests. And often it had to be multiple different tests in order to have enough testing capacity to meet our patients' needs. But then very quickly after that, it wasn't just testing. It was every aspect about getting a specimen from a patient to the laboratory. And that was from the swab that was inserted into the nose or nasopharynx to collect the specimen, to the transport media that the specimen went into, and then to the laboratory, and then getting the testing supplies. So those were challenges that pathologists had to face, and became very innovative and creative in coming up with alternatives, such as creating their own swabs and coming up with alternative media for transportation. And then as the manufacturers began rolling out COVID tests, they had to shift their gears away from other tests that they were usually making. And then that created more supply chain challenges because we couldn't get other tests because all of the resources had been devoted towards COVID testing. Now, today, we still do see some supply chain limitations. Some of that has to do with numerous global factors, not just the pandemic. So we still see shortages on things like plastics and tips and even standard plates that we culture bacteria on, but they have been getting better, which has been very positive.
Thank you, Dr. Pritt. Now, Dr. Miles, back to you. Is there current legislation that helps laboratories and physicians prepare for new COVID variants and, the possibility of future pandemics?
Yes, absolutely. Currently, Congress is considering the Prevent Pandemics Act. We at the CAP support various provisions in that act, which will help prepare us for future pandemics. Now, some of the specific provisions we're going to talk about now, here's what the bill does. One, it increases genomic sequencing, analytics, and public health surveillance of pathogens. Actually, $175 million is allocated in each fiscal year from 2023 to 2027 to strengthen and expand activities related to genomic sequencing. And this is important so we can track the various variants out there and devise optimum therapies. The second thing is supporting epidemic forecasting and outbreak analytics by the CDC. And then also an important point is improving access to specimen samples and diagnostic tests by laboratories. When a variant occurs outside the U.S. or a new pathogen is present outside the U.S., we want our laboratories to quickly develop tests and validate tests. And if this legislation is passed, this will help the laboratories be able to access specimens to validate the new assays that are coming out. And then other things in the bill which are important. Yes, modernizing and strengthening the supply chain, which is important at all. And for all, and then also addressing social determinants of health. The bill would authorize $70 million in each fiscal year from 2023 to 2027. And one of the things that we've learned from this pandemic is that disparate, underserved populations are more vulnerable to the COVID-19. And we need to study social determinants of health so that we can improve health outcomes going forward.
You know, some of the most difficult situations teach us a lot. And certainly this pandemic has been a great example of that. I've noticed significant scientific advancements that have come out of this pandemic that hopefully will help us in future pandemics. You know, certainly with this pandemic and the development of the vaccine, the public health community saw the benefits of genomic sequencing, which you just mentioned, Dr. Miles. We really need to fund more research in this area, not only for current coronavirus pandemic, but also for other diseases. The other thing is that the global pandemic was the first time that we had these powerful surveillance tools and that they were put to use for the general public's well-being. You know, the ability to sequence the genome of the virus has been essential to tracking it, making the experience with this virus so different from previous viruses and pandemics. Dr. Pritt, do you have additional thoughts on the kinds of scientific advancements we've seen from the COVID-19 pandemic?
I do, Dr. Volk. There have been numerous. We have everything from rapid implementation of genomic sequencing for tracking the virus and its variants over time. We also have some of the things I mentioned earlier, such as laboratories creating some of their own media for transporting swabs, 3D printing their own swabs, using novel specimen types such as saliva for detecting respiratory pathogens. That's just not a source that we used in the past, and we actually found that it's a pretty good source. Looking at ways to conserve on supplies, such as pooling specimens and testing them all together with a highly sensitive test. So there have been many things. I think the pathologists really just came together in this time of need. Now, with all of this comes all this information, and that's been challenging for the public, I believe. So something that's been very important is pathologists then helping the general public and our physicians, our other physician colleagues that we work with every day to understand what these new innovations mean and to, as subject matter experts, really help them understand what the types of tests are that are available.
Thank you, Dr. Pritt. At this point, let's talk a little bit more about the impact of COVID-19 on pathologists and the access to diagnostic patient care. I think we all have noticed that inflation is at its highest point in the nation since the early 1980s. I have seen an increase in personal inflation, which increased cost pressures on hospitals who are scrambling to hire staff. As a CMO, I know that hospitals need to be fully staffed, not only to prepare for future pandemics, but also for patient care. And in order to combat the rising costs of inflation, hospital staffing, and including pathologists, they're increasing the number of hours for staff. So Dr. Pritt, how has inflation impacted laboratories and access to patient care at the Mayo Clinic?
We've certainly seen inflation and its impacts, and it really impacts every stage of testing, from raw materials to transportation of reagents to manufacturing. And at this point, we've been able to protect patients, and I hope that as pathologists we can continue to protect patients as our primary goal as physicians. But I do have concerns that continued inflation could have an impact on patients by pushing costs onto them.
Yeah, absolutely. Dr. Miles, what are your thoughts?
Well, there's no question. We all know that the consumer price index has increased quite markedly. But although the CPI has increased, Medicare payments have not increased at all. And this certainly has created pressure on the system. And certainly when you create pressure on the system like this, the laboratories that are operating with minimal margins, these are typically in vulnerable healthcare population areas and healthcare deserts, both urban and rural areas. These areas are most threatened by these cost constraints that we're dealing with. And certainly the laboratory workforce shortages have been exacerbated by the increased demand for COVID testing. We certainly have issues, pipeline issues, both for pathologists as well as non-physician workers in the laboratory, burnout among everybody, and it's all been exacerbated by the COVID-19 public health emergency.
You know, we talk so much about nursing shortages in this pandemic, and I think it's important to share that the behind the scenes workers, the laboratory workers, the pathologists are so critical here. So thank you for sharing that. Dr. Miles, can you tell us a little bit more about how laboratories and pathologists have been affected by the pandemic?
Yeah, we at CAP did a practice leader survey in 2021, and 9% of our practice leaders indicated that a hospital or independent laboratory, which they were contracted, has actually closed in the past 2 years. And 76% of those where this occurred, 76% of people thought that it had a negative impact on their practice. We are facing in pathology Medicare cuts in 2023, which does have the potential to impact laboratory care for patients. We at the CAP were successful in mitigating cuts in 2021 through 2020 and 2022. But if the cuts that are proposed for 2023 do take effect, we feel that they will disproportionately affect access to health care in the most vulnerable populations, that is the inner city as well as the rural community health centers. These folks do not have any fat to cut. And what would happen is if we have closures in these areas, care would not be readily available locally, and some patients may have to drive 100 miles to get health care. One of the things that we learned from the pandemic is it's important to get testing close to home. We need those results quickly so that the appropriate treatment can be instituted.
Absolutely. I know for sure, I've heard from physicians working in the rural areas throughout our country, and not having quick turnaround time tests early on in that pandemic was a real challenge for treating patients in the hospital. Dr. Pritt, what have you seen from your perspective?
Well, I agree with everything that Dr. Miles said. And I'll also add that it's really brought to the forefront the work that pathologists and the laboratories that they direct what it's brought attention to what we do, because pathologists had to be innovative and we had to be communicators to help communicate to our colleagues, to the general public. And I think it became clear a lot of information was coming out about testing, and there was a lot of confusion, and pathologists really stepped up to the plate to provide accurate information in the sea of misinformation that was available. And so I think that pathologists, just looking back at the role pathologists play, it's everything from determining a need for a test, evaluating a test, selecting it, bringing it into the laboratory, performing the validation studies, and then making sure that it has quality, that you have quality systems in place so you always have accurate results. And that became apparent, I think, to the general public, the role that pathologists played. Things like PCR and cycle threshold became part of our common language. And that was a good opportunity for pathologists to really help educate.
Despite of all the tragedy associated with this pandemic, I must admit I've never been prouder to be a member of this physician community than in the past 2 years. The COVID-19 pandemic has impacted the healthcare workforce and has highlighted a shortage of physicians. In particular, you know, as Dr. Pritt mentioned, it has highlighted the role that we pathologists play in the healthcare system. it's really important that we have an ongoing supply of new pathologists entering the workforce as we move forward to continue doing this critical work. Throughout the House of Medicine in the United States, we are seeing broad shortages of up to 124,000 physicians by 2034. So that's right around the corner. Expanding the number of graduate medical education slots is key to helping address this critical shortage. Without the funding and the commitment to expand graduate medical education slots, this shortage will only grow. Dr. Miles, is there anything that Congress can do to address this pending physician shortage?
Thank you, Dr. Volk. Yes, actually, the CAP does support the Resident Physician Shortage Reduction Act of 2021, which will take some steps to alleviate some of these challenges. And what this legislation does is it provides for 14,000 new Medicare-supported graduate medical education positions over a period of 7 years. And these positions would be for teaching hospitals with diverse needs, including rural hospitals and hospitals serving patients in health professional shortage areas. Now, it's not just physicians we're talking about. We are experiencing physicians of laboratory professionals that are not physicians as well. And also a significant number of these individuals are expected to retire in the coming years. Certainly as people leave the system, the strain is felt by those that are left behind when we have to perform the same amount of duties with less people. We at Cleveland Clinic are actually starting a phlebotomy school this year to help alleviate some of those shortages that are before us. What we really want to do is to avoid any increased wait time to get laboratory results because, again, getting those results as quick as possible without any delay is important so that appropriate treatment can be instituted.
Yeah, absolutely. I know that Cleveland Clinic is becoming very creative with dealing with the healthcare worker shortage. I can tell you here in the Louisville metro area, we are also partnering with our local community colleges, such as Ivy Tech, to create and support phlebotomist programs, med tech programs, and so on. Dr. Miles, are there other issues the CAP is actively lobbying Congress and the Biden administration to address that you'd like to share?
Absolutely. It is National Minority Health Month, and the CAP is calling on Congress to support legislation addressing social determinants of health. We've sent a variety of letters to federal legislators. We support the bipartisan legislation that's out there that brings healthcare agencies together to tackle social determinants of health and improve outcomes for the patients that we as pathologists serve. There's another piece of bicameral legislation that we at CAP support to coordinate healthcare data at the federal and state levels, including data derived from laboratories, by enhancing the electronic reporting and syndrome surveillance. The thrust of these initiatives is to enable a better understanding of the social determinants that drive healthcare disparities in America. Federal agencies such as the CDC and the FDA have moved to improve healthcare data collection, and we encourage that. Given the important role that laboratory data has today, the CAP is engaging with these agencies on discussions that involve laboratory data to represent pathologists and the laboratories that we direct.
This has been a great discussion, but let's open it up to the media attending today for additional questions. We'll start with the questions that were submitted by attendees in advance of today's media briefing, and then we'll work our way through the list. We will certainly try to get as many possible in the time that we have left. And if we don't get to your question because of time, we will make sure and get those questions answered after the briefing via email. So let's go to the first question from Jeremy Olson from the Star Tribune regarding COVID-19 PCR tests. Dr. Pritt, I think this one is for you. COVID-19
Yes.
tests, yes, thank you. Dr. Pritt, COVID-19 tests have always been presented as qualitative in nature, but did we underappreciate or underutilize their potential quantitative applications?
So I think that is an excellent question from Mr. Olson. And I would say that in general, we should not try to turn a qualitative test into a quantitative test. Now, there has been a lot of talk in the scientific community among pathologists about what information we could get from a qualitative PCR test for SARS-CoV-2. And the information we would get would be in the form of a CT value, that cycle threshold. It's an estimate, a rather approximate, of how much viral RNA is in a specimen. The higher the number, the higher the CT value, the less the RNA that's present. Some people have used that as a measure of infectivity, but we have to remember that there is no true reliable measure of infectivity at this point. And a CT value is variable. These tests are not meant to be quantitative. They aren't standardized, and they don't use a standard that would allow you to compare one CT value in one test to a different test in another laboratory, or even to a different test within the same laboratory. Also, think of the CT value as an approximate measure of the amount of viral RNA in a sample, and ask yourself, how could that amount change? Well, we know that a patient has a varying amount of virus throughout their infection period. If you happen to test the patient early on, before they develop symptoms even, they may have a low level of virus. That doesn't mean that they're not necessarily infectious anymore, and the very next day they could become very infectious. We also know that the quality of the collection, how vigorous the swabbing is, will impact the amount of viral RNA that's collected. So a collection that isn't as vigorous is going to pick up less viral RNA. That doesn't mean that the patient doesn't have a lot of virus in them that they could spread to others. And then the specimen type. We have to think about the fact that a nasal swab won't necessarily contain as much viral RNA as a nasal pharyngeal swab or a throat swab. And then last but not least, the tests are not standardized against one another. And so, as I mentioned earlier, a CT value determined by one test isn't necessarily comparable to a CT value determined from another test, even when testing the exact same sample. And the College of American Pathologists saw this, and we published this early on in the pandemic. We sent out proficiency testing specimens to laboratories around the country, and it was the exact same specimen type, and we looked at the CT values that were produced by all the different laboratories, and the CT values ranged as much as 12 cycles. So for example, one laboratory could say there were a CT value of 20, another laboratory would say a CT value of 30. So if you said that a cutoff of 25 means someone's infectious, well, what does that mean? It's the same exact specimen, and yet you have two different answers. So that's a rather long answer to a question that I think the short answer to is it is premature at this point to try to take a qualitative test and interpret it in a quantitative fashion. Now, does that mean that there is no role for quantitative testing? I think that's something that pathologists need to look into further with a true quantitative test, where it actually uses a standard to produce an actual measure of viral copies per specimen per milliliter, rather than just an estimate. So that's an area that we can continue to study in the future.
Thank you, Dr. Pritt, for that very thorough answer. I know that these new terms like cycle threshold are a lot for the public to understand, but thank you for explaining that so beautifully. We now have a question from the New York Times. This one is for Dr. Miles. Looking ahead to the next pandemic, how do you think the FDA, CDC should handle authorization and recommendation of PCR tests versus rapid tests? What do you think worked well this time around, and what should be done differently next time?
Thank you for the question. Nobody saw this pandemic coming. So, and we in the laboratory adapted to the pandemic by getting the testing going up as quick as possible. The government also did not foresee this pandemic coming. And going forward, it's my opinion that the government will learn from this and will make adjustments going forward. The important thing is that, you know, we're in the pandemic now. We're still dealing with the pandemic. So there'll be time after we get through this pandemic to better prepare for the next pandemic. I think that the government did demonstrate flexibility and did adapt regulations as the pandemic has evolved, and that there has been flexibility. I think there will be further adjustments in the future. What exactly those adjustments will be will depend on a thorough analysis of this pandemic. But I think that in anything going forward, we put the patient first. And what we need to do is we need to provide for accurate testing in the quickest possible way for the most people in order to contain these pandemics. And one start is the Prevent Pandemics Act. We know that there's different variants of the coronavirus, and the testing tests may or may not detect various variants. And that's why we need our laboratories to have access to some of these variants that are not yet in this country, so that we can develop rapid testing. And the Prevent Pandemics Act will help us do that.
You know, Dr. Miles, you mentioned that how flexible and how responsive laboratories were across the country in 2020, bringing up testing very quickly. I liken it to building an airplane while we flew it. And despite our abilities to be that flexible, I think having more preparedness in the future is, I agreed, the right thing to do. Here's another question from MedPage Today about at-home testing accuracy, rates of false positive and false negatives. Dr. Pritt, in the past, CAP has expressed concern that people who have infection and are contagious may receive a clean bill of health. Now we have looming unknown variants. Are you still concerned about at-home testing results possibly missing some infections?
That's a great question, Dr. Volk. I think it's a complicated question because there are different times that you would want to use an at-home test. Now, for example, someone who is starting to develop symptoms of COVID-19, for example, they have a fever and a cough, well, they can take an at-home test. Usually that's an antigen test, which is less sensitive than our gold standard PCR test. And it is true that this antigen test, being less sensitive, may be falsely negative, especially early on in disease. But if it's positive in the right setting, that's a pretty good indicator the patient has COVID. So in that case, having a rapid positive result would be helpful. Having a rapid negative result in a patient who still has symptoms would not be helpful, and it would indicate that that person should then go and get an actual PCR test at a laboratory. Now, there are other reasons that we use these at-home tests, and we've learned a lot during the pandemic that they can potentially be used after someone gets over their infection from COVID. It's been 5 days, they no longer have a fever, and they want to go back to work. And the CDC now recommends using a rapid antigen test, which is available over the counter, to determine if they would be safe to go back to work with still wearing a mask and maintaining social distancing. And so if it's been 5 days, the person hasn't had a fever without taking anything that would suppress a fever, and they have a rapid antigen test that's negative, that would indicate that they could go back to work as long as they continue to distance and wear a mask. We've learned a lot about all of this, and I think early on it was also tricky because we didn't know how to keep each other safe. Now we know that a combination of testing, masking, and distancing can be used for these different strategies.
No, thank you for that, Dr. Pritt. We have another question for Dr. Miles from Genome Web. The The Biden administration has said it wants to establish a single unified mission control office within the HHS that will be in charge of pandemic preparedness. I'm wondering how realistic establishing such an office is, what progress has been made in that direction, and if there are any competing proposals out there that call for putting that authority or organization in a different part of the government or otherwise organizing it in a completely different way.
Well, first of all, there's no question that we need to develop a plan uh, for preparing for future pandemics, no question. And we've learned a lot in this pandemic already, and we continue to learn every day. You know, the thing is, the laboratory community certainly got testing ramped up in a hurry. Um, we had to cross-train our personnel to meet the demands in the various laboratories. The other thing that the pandemic really brought to light was the supply chain issues that we had. And the one of the things that the government has taken steps to do is to look at that supply chain. And also the laboratories have also looked at the various suppliers that they do have. So yes, there is the office in HHS that is looking at that and developing that. In terms of what else is going on in the executive administration specifically, I can't speak because I'm not privy to all the information that is going on in government. But I think the important point that has been made by the question is that it's important for government to prepare. We need adequate supplies, we need adequate distribution, and we need adequate resources where we can go with questions when we have issues with the supply chain.
Thank you, Dr. Miles. Absolutely agree with you that preparedness saves lives. And I'm so glad that our government is thinking along those lines for the future. We have a question from a viewer on YouTube. The viewer says, I'm immunocompromised. What can be done to make the average family prepared for future pandemics so we can protect ourselves and not see our basic needs unavailable or unmet in the future? Dr. Pritt, would you like to try to answer this question?
Sure, Dr. Volk. I could start. I would say that if that was my family and someone in my family was immunocompromised, I'd probably add to my emergency preparedness kit things such as masks and hand sanitizer and different cleaning sanitary supplies. We certainly know that early on in the pandemic, it was almost impossible to find hand sanitizer, and there certainly were no masks. So I would probably start by stocking up on those.
That's a great point. Thank you. Thank you, Dr. Pritt. We have another question concerning the recent mask mandate changes. This week, a federal judge suspended masking requirements for air travel ahead of the CDC direction and citing federal overreach. Now, the Biden administration may challenge this. Because of the projected uptick in COVID, what are your thoughts on relaxing the masking guidelines now? I'll start on this one. Uh, I just don't think wearing a mask is that big of a deal for most of us. And we know that wearing masks can reduce your risk of contracting COVID 19, and it can potentially reduce the risk of exposing others. So, regardless of what the mandates say, I can tell you that my family and myself and I tell my friends and patients that I see to wear a mask in public transit, especially in close quarters. Um, Dr. Miles, we have a question regarding what's just happened on Tuesday. The White House held an event announcing the new Center for Forecasting and the new Center for Forecasting and Outbreak Analytics under the CDC. The new center will provide forecasting for infectious disease. Dr. Miles, what is the pathologist's role in infectious disease forecasting, and how will laboratories use information developed by the new center to prepare for outbreaks in their communities?
Yeah, this is a great new program. It was just announced. I believe $200 million has been allocated it too far, and certainly forecasting spread of an organism and where the pandemic will go is very important, so we can plan and mitigate. So one of the things about forecasting is that it involves data and test results. So we as pathologists, as leaders in the laboratory, are instrumental in making sure that the test results that are provided are accurate. So that's a primary role for all laboratories throughout. Also, we as pathologists play a role in reporting the data to the government. And another lesson that we've learned in the pandemic is that the data has to be readily reportable and easily reportable. And that's something we at the College of American Pathologists are actively involved with now in government, is to making sure that that data can get from the laboratory to government so that it can be used to plan in these pandemics.
Thank you, Dr. Miles. Well, our time is about up. I want to thank Dr. Pritt, Dr. Miles, and all who participated and submitted questions today. I want to urge the media who joined us to please continue to reach out to the College of American Pathologists for any information and comments when it comes to laboratory testing, including COVID-19, or for any follow-up information from today's briefing. Please visit our multimedia newsroom to view this briefing again and for other information about pathology and pathologists. Again, thank you for joining us today.